Right, so here we are, pressure damage risk assessment and categorisation. So we're going to be looking at the risk factors associated with pressure damage, how to accurately categorise pressure damage ulcers, and then we're going to be looking at the Braden risk assessment tool as well. Do we have any children's nurses with us? If you could turn your mic on and tell me if you're there. I'm assuming that's a no. Okay, because there's a slightly amended Braden tool for them, but I won't spend too much time on that if there's no children's nurses here. Okay, so starting at the beginning, what is a pressure ulcer? So this is the European Pressure Ulcer Advisory Panel in 2010 defining a pressure ulcer, and we call them ulcers, not sores now, so they're not bed sores, they're pressure ulcers, is localised injury to the skin and underlying tissue, usually over a bony prominence, so it's not in the middle of your thigh, it's over a bony prominence, and it's as a result of pressure or pressure in combination with shear. And of course we know as well that friction does sort of play a part too. So there are three forces generally that come into play when the development of pressure damage. So direct pressure, so this is the normal force exerted when two surfaces are in contact with each other. So I don't know what you're doing now, I'm sitting in a chair and the weight of my body in contact with the surface underneath me, I can feel on my ischial tuberosities that the weight of my body pressing down, and that is the direct pressure that's being exerted on those tissues in between the bone and the surface of the chair. Then we have shearing forces. So these occur when, so it's shearing of soft tissue when forces moving in different directions are applied to the same tissue mass. So it sounds quite complicated, but it's quite easily demonstrated by this sort of picture of people sort of sitting half propped up in bed. So the weight of their body is the gravity, is sort of pulling the weight of their body in a sort of a downward direction, but their bottom is in contact with the bed, so the body wants to go one way, the skin is staying in another, and you get this sort of drag and pulling effect on the tissues in the area there. And then friction, so this can increase your risk of pressure damage, and it's the rubbing of skin over a surface. So it could be somebody with a tremor or with restless legs, or actually poor manual handling. Somebody's repeatedly being moved on the bed and they're not having a slide sheet put underneath their heels, and their heels are being dragged up the bed there. It can also be done in sort of, it can be part of transferring techniques, so people sort of scuffing forwards in a chair or on a bed. So the areas of the body at greatest risk is kind of where your weight comes into contact with the surface, so where bony areas sort of come down really. So if you're lying on your back, it's the back of your head, your shoulder blades, your vertebra, elbows, your sacrum, heels, toes. It's got thigh on there. I don't often see pressure damage on a thigh, but I guess if there's something the back of the thigh when you're in a chair maybe, sometimes people with chronic edema and the ridge on the edge of a chair, they can get pressure damage there. Lying on your side, your ear would come into play, the top of your shoulder, your trochanter of the femur, the classic bony bit on your hip, and then your malleoli as well, all areas where your weight comes into contact with the surface. Okay, so we just got an extra slide of your anatomy because we get quite a lot of dubious descriptions of anatomy coming through with sort of pictures and descriptions of ulcers on the sacrum when they're very clearly on the hip, for example. One of the clearest things that people don't get right is your ischial tuberosities, so your ITs. So if you're sitting down and sitting upright, it's the bony bits directly underneath you, and these are the areas that suffer pressure damage through sitting, and it's important to be clear on your anatomy because it does give you clues as to which position the person is in that's causing the pressure damage. So your ITs are classic areas for sitting, so they help guide you to what you need to look at, to where to go to try and solve the problem of what's causing the pressure damage. And sometimes people get confused because it can be right in your gluteal fold at times, and you say, oh well, it's not on the bottom, it's on the leg, it's at the top of the thigh. Well, that would be the ITs, and yes, it would still be pressure damage, that. So that's just to identify your anatomy a bit better. So common risk factors, all sorts of things really that can put you at risk of pressure damage. Top of the list, previous pressure damage. We should always be, when we're assessing people of risk, finding out if they've had pressure damage before, because they're at much higher risk of having it again. Clearly, poor mobility, not changing your position, being in one place at the same time, rapidly followed by seating and positioning. So thinking about the shearing forces and direct pressure from the pictures that we've just seen, you can see clearly that sort of poor positioning in chairs or being in one position for a long time have a big impact. So care environment, you need to be thinking about medical devices and equipment. What is the body in contact with? So, you know, it could be a face mask from CPAP or something, could be oxygen tubing, it could be a neck collar. It's not just the classic, what are you sitting and lying on? So your mental capacity, cognitive state will impact, as will psychosocial factors, concordance issues, any acute and chronic illnesses, and you can see these are really broad. There's a lot of things that will impact this. End of life. Clearly, as your circulation starts to shut down, your tissues are less perfused, and that puts you at higher risk. Some medications like steroids put you at higher risk. They're thinning the skin. Manual handling techniques, how people are transferred, and the extremes of age, so very young and very old. So there's a huge amount and an awful lot of different assessment tools out there that will be helping you gather some information. What we advise in this trust is that you use the Braden risk assessment tool to screen every single patient for their risk of developing pressure damage. And then we use the S-Skin bundle as another framework for structuring your assessment, if you like, and focusing on key areas and for your management plan as well. So the skin bundle assessment and management plan bit is going to be done by Lauren next week. So we're just going to go on and look at the Braden tool now as your screening tool. So this is kind of what it looks like. This is the adult version of the Braden tool. So you have on one side the categories and the descriptors, and then on the other side of the form you have the space to be doing repeated measures of somebody's Braden score. This is the paediatric version. It's called the Braden Q. It's very similar. There's a couple of extra categories. Where are we? Or I'll get back to that later. There's a couple of extra categories to it, and there is more information on the website about it as well if anybody wants to look at it. But I'm going to skip on because it didn't sound like we had any paediatrics or children's nurses with us. So, Braden risk assessment tool then. I don't know if anybody's been around as long as I've been around, you'll have remembered the Warsaw tool. If you've come from the acute sector, you might have had the Waterloo. There's all sorts of other tools out there for various different settings, critical care and the like. And the Braden tool is actually the most validated risk assessment tool. It's recommended by NICE. None of them are perfect. There's drawbacks on all, and I think sometimes people have issues with the interpretation of the categorisation with the Braden tool, and we'll look at that a little bit more in a second. But it's as good as it gets for the community, which is why we use it. And the rules are, and this is set down by the government, that in an inpatient facility, it needs to be completed within 6 hours of admission, and in the community on the first visit to a patient's home, and there's no ifs, no buts on that. So who does do the Braden risk assessment tool? Well, that might be different for different settings. There may be different rules for different services as to whether it needs to be a qualified nurse, whether an assistant practitioner is able to do it, and you will need to check with your local workplace as to what the rules and things are there. How often? Well, how often will depend upon a number of different things, how stable the patient is, what the level of risk is, whether you think that their condition is changing. When it changes, you definitely need to do it then. So if somebody develops a fever, for example, that would put them at higher risk, and you should be redoing the Braden risk assessment. So if they've had a fall and their mobility has changed, you would need to redo it then. if they've been into hospital and come out again, you would need to redo it then. So it depends, and you need to be mindful of that and think, has something changed? Do I need to redo this? So the tool itself has 6 elements. It covers sensory perception, moisture, activity, mobility, nutrition, and friction and shear. And it's a scoring system. So on each of those elements, you score them generally between 1 and 4. I think there's one that has 3. And then you tot up the value at the end, and it gives you a single figure, and you compare that against the scale. So here are the different elements and the scoring sort of system. So they would score sensory perception, maybe they'd score 1, moisture maybe 2, and you get to the end, you'd add it all up and you'd get your final score. So we're just going to go through these elements in a little detail, just so that people are clear and are using them properly. Because if you don't read them and understand them and know what they're describing, you could select the wrong one and get an inaccurate score at the end. So the first one, sensory perception. So this is about somebody's ability to respond to pressure-related discomfort. So, you know, when you've been sitting for a long time, you get pins and needles and numb bum. There's nothing worse than sitting in a training session on a rock hard chair. You're shifting in your chair and moving your position, and that's because you've got all the sensations saying, oh, you know, blood's not getting through, you need to move. So anything that could compromise somebody either receiving those messages or understanding those messages would be scoring here, really. So and you'd be using your AVPU here as well. So somebody who's unconscious clearly isn't going to do any of that. But you might have somebody with who's fully conscious but has a neurological condition and isn't able to sense anything. So that could be a spinal injury, but it could be something like motor neurone or MS. But also it could simply be a sort of a peripheral neuropathy. So a lot of older people, certainly diabetics, will definitely have peripheral neuropathy in their feet, and you need to know about that and score that here. And may even, you know, in their sacrum too. I've met a diabetic who couldn't feel what was going on with the pressure sore on her bottom at all. So you need to find out, can you feel this, and the like, and then consider, are they able to respond to that? So yeah, can they go, oh, I feel uncomfortable, and then change my position? So somebody with dementia may not be able to do that either, for example. Moisture. This isn't just incontinence, this is sweat as well, and how the degree to which skin is exposed to moisture. You know, even somebody with a catheter, the catheter might be constantly bypassing, so you'd need to sort of think about that. And it's the frequency that the skin is exposed to that moisture. Activity. Now there are 2 sections on, you could say, is about movement, and I think that sometimes people get a little bit confused. So we've got activity here, and then the next one is mobility. So let's look at a little bit more detail in this. So degree of physical activity. This is ranging between somebody confined to bed who is virtually unable to walk, can't bear their own weight and has to be helped to stand, to somebody who can walk but doesn't do it very often and only walks short distances, I mean, is sitting for quite a long period of time, and then to somebody who walks frequently. So this is about standing up, getting up, and moving, walking. Whereas ability to change and control body position is not necessarily that. It could be somebody who is bed bound but wriggles in bed. It could be somebody that is chair bound but moves around in bed. And you need to be looking at how much do they move, how much do they slightly change their position, and how frequently do they do that. So there's the 2 aspects of mobility there, and you need to think quite carefully about that. Okay, nutrition. Absolutely massive nutrition when it comes to pressure damage. Let's just put a big red flag up there now. I think the EPUAP guidance sort of kind of says in big letters that the second most important thing to preventing and healing pressure damage, second only to removing the pressure, is nutrition. So yes, you want to remove the pressure, but the very next thing that you are thinking about is nutrition. And so you cannot underestimate how important this is, and therefore how important it is that you do a really good assessment of this. It's not okay to go, yeah, they eat 3 meals a day and somebody makes some sandwiches, and yeah, you need to think about how much protein that is giving somebody, what is their body weight, and how much protein are they getting. So this actually gives you a decent bit of general guidance about how many times a day somebody eats and how much of a portion they eat to help you judge which category they go into here. So for example, adequate, they eat over half of most meals. They eat a total of 4 servings of protein each day. They might refuse a meal, but might take a supplement instead. And I can think of very many patients that we get referred who aren't even close to adequate. So please do look at that one in detail. And then friction and shear. Okay, so and this is sort of, it could be their posture in bed. So you need to look at them when they're in bed and go, are they bolt upright? Are they completely flat? Or are there some, they up slightly? So there's some shearing forces. Anything I can do to reduce that. What's their sitting position in chair? Watch them from the side in the chair. You know, are they slumped? Do they sit upright? And consider that. And you also need to consider in this their transfers. How are they transferred out of bed? How do they get out of the chair? Are they scuffing their bottom forward? Are they being dragged forward? Are they using a slidey banana board and getting some friction that way? So you get your total score at the end of it, and then you look at your score, you compare it to the categories, and it puts you at either severe risk, high risk, moderate risk and mild risk. Just another red flag. I think we've been using this long enough to know this, but the previous Warsaw score, it used to be a high score was high risk. Well, this is the exact opposite. A low score is high risk. So if you're scoring 2, don't go thinking, oh, that's okay. It's like, well, you can't score 2. You know, less than 9 is severe risk. However, if they have pressure damage, you do need to do that, but they will always be on high risk. They're always straight to the top with pressure damage. So even if you get a score of 15 to 18, you would always be scoring them on high risk. And it isn't just about the numbers. So if you do this and you go, nah, no, I'm sorry, you know, and you go back and you look at it again and you go, no, I really do think there is greater risk here than that. If you, on your clinical judgment, you think it's higher risk, well, then you go in and you put them on the higher risk. Your clinical judgment is another trump card. So current pressure damage and your clinical judgment will trump the score. Okay, so these are the additional bits that come on the Braden Q. They have a couple of extra things that we don't have on the adult one. Okay, so that's a whistle stop through that. Right, pressure ulcer categories. So EPUAP, category 1, intact skin with non-blanching redness of a localized area, usually over a bony prominence. Okay. We also, not necessarily from district nursing, but we do get referrals going, and oh, they've got category 1, it's blanching erythema. It's like, it's not category 1. Category 1 is non-blanching. That's not to say that erythema over a bony prominence isn't a problem. It is, and you need to be observing how long it takes for that erythema to go away. And it's a warning sign, you know, the react to red thing. Yes, it's a warning sign that the pressure forces are occurring here, but it isn't actually yet category 1 pressure damage. So it's only category 1 pressure damage when you, I'm hoping you all know how to do this, the sort of blanching test to see if it's category 1 or not. So you find an inflamed area. In this example, these heels are quite pink. In the second picture, you can see a thumb is being pressed onto that area firmly up to a count of 10. And If you have got intact circulation, as soon as you take your thumb off, you should see a little white area like you've got in that picture there. What that means is that the pressure you've put on has squeezed the blood out of the little capillaries underneath. And what you then should see is within a few seconds, 2 or 3 seconds, the white area will go back to being pink and the blood has flowed back into the area. And that tells you that the little capillaries there are intact. If they're not, what you get is when you take your finger off is no white area, it stays pink, and that tells you that those capillaries are already damaged. There's already been injury to those little capillaries, and that is category 1 pressure damage. Now I'll just go back a second to this slide here, because there are other things that you need to do, not just look. You do need to feel. Is it hot? Is there a texture difference? Sometimes heels go all sort of soggy and soft and squidgy, don't they, when they're in this first stage of pressure damage? So look for temperature, texture, colour. Compare it all to the surrounding tissues. A little bit more difficult in pigmented skin. You might not be able to see sort of visible blanching. The colour sort of like might be slightly different, but you would, using all of the other feeling and heat and texture sort of things as well will help you with that. And also, of course, pain. Okay, so that's category 1, intact skin. Category 2 is partial thickness loss of the skin. So this is a really good picture for that. You can see that a very, very thin layer of skin has come off the top. It's not all the way through. It's very sort of superficial, often sort of shiny and pink. You don't get slough or deep purple bruising with category 2 on an open skin like this. What you can have that's also a category 2 would be what's called a serosanguinous blister, and that's often what you see on heels. You find a blister but it's got blood within it, and that makes it look purpley. That in the early stages is a fluid filled blister, but a week or so later, as that fluid has been absorbed, what you end up getting is a hard sort of black scab sort of appearance that people often get confused with the category 4 pressure ulcer, but is in fact just the drying out blister that in 3 or 4 weeks the scab will just peel off and there'll be intact skin underneath. So a serosanguinous blister, a blood filled blister, is also a category 2. This is all down to pressure, of course. It's not a skin tear, a burn, or incontinence associated dermatitis, or indeed even moisture damage. Okay, so category 3, this is where you've gone through the skin, all the way through the skin, and you're through into the tissues beneath, into the subcutaneous fat, but you're not going as far as bone, tendon, or muscle. Okay, so you're just into the fat layer here. So you may well have slough at this point. You would be able to categorise it as a 3 if you were able to see the wound bed. You may get, as in this photograph, you may get some undermining and a little bit of tunnelling, but you definitely won't be able to see or feel bone and tendon. Category 4 is full thickness tissue loss, where you are down to bone. You may not be able to see it. It may be a case of you can feel it directly. So sometimes on people who've lost a lot of weight with pressure ulcer on the sacrum, sometimes you can really clearly feel the wound bed and you can see a little bit of flesh over it, but actually it's not even a millimetre thick. You can feel the bone there. That would be a category 4. Not just bone, it doesn't have to be bone exposed, it can be tendon or muscle or any supporting structures, so fascia or joint capsule, and because these structures are exposed, it makes osteomyelitis more likely, and you may well have slough and eschar. You can see a bit of both in this sort of picture here, so that we could categorise as a 4. This is what's called now deep tissue injury. This is not to be confused with category 1 pressure damage. If you've got this purple tinge to this damage, that is the sort of maroon discoloration, that is an indication that you've got some deeper tissue damage than just those little capillaries there. So the skin will be intact to start with, the tissues might feel boggy in there. However, after a few days, certainly that heel on the left, that will turn into black, hard eschar. This is not a bruise. This purple bit here over a bony prominence, that is deep tissue injury. And then this is what we now call unstageable. So it's highly likely that this goes down to bone, but because there's a whole pile of stuff in between the bone and what we can see, and we can't see down to the bone, we currently call this unstageable. And it's full thickness tissue loss where we can't see the base of the wound because it's covered with slough and eschar. Once debrided, you then would resubmit a categorisation of this wound when you'd found out exactly what it was. Don't forget medical device related pressure ulcers. Most of these are going to be sort of a 3 or a 4 probably, because of they're usually sort of fairly close to bony areas. So things like bridges of the nose. I don't know if people have seen pressure damage there from things like masks. They can go very quickly. There's very little tissue there, and it goes very quickly down to the bone. So that would be categorised as a medical device related one. Okay, so just to raise your awareness of how deep pressure ulcers develop. Often it's all happening down below, and you only see it on the skin when it's been some time after the event. So the forces are such that when you've got this significant pressure between the bone and the surface that you're sitting on, the tissues in between, where it's identified there as the cone of pressure, they suffer the pressure damage itself, and that's where the tissue sort of necrosis happens. And it happens more close to the bone than it does close to the surface of the skin. And that is why you can start off with quite a small ulcer, but then as it debrides, it opens up into quite a large cavity. So when you think, oh, it's not very big on the surface, actually it probably is, because it's all happening down below. So, moisture or pressure damage. Let's have a little look. So moisture damage causes, obviously, moisture is being caused by a liquid, usually incontinence or sweat against the skin. Sometimes it can be in an area where pressure is. So typically on the sacrum, you know, moisture can be coming into play. So you can't just go, oh, it's on the sacrum, therefore it's pressure, or therefore it's moisture. You need to think more about it. Moisture damage is usually shallow. It often has irregular edges. You can also get the linear form. So, you know, in the natal cleft in between the buttocks, you can get that little yellow line of slough, if you like, in there. That's not pressure damage. That linear thing tells you that's moisture damage. OK, so that's quite a classic sort of telltale there. But you can get this sort of butterfly pattern of moisture lesions. Let's go back to these pictures here. So the second picture, so the first one you can see is the linear moisture one. The second one you can see these very irregular edges, very shallow, and a butterfly effect on the two buttocks. That's quite typical of moisture. All that red inflammation excoriation doesn't, you know, it clearly tells you you've got, you know, a continence issue going on there that's sort of stripping the skin. And then those would be good examples of moisture. Pressure, on the other hand, if it's a pure pressure ulcer and no shearing sort of friction forces, often the pressure damage will be quite circular. So people who are sitting for long periods of time on their ITs, quite bolt upright, often you'll see their pressure damage is really quite circular. So a very circular one will make you think this is direct pressure. If you've got shear forces in play, often you get this teardrop appearance, and this picture number 4 here is a good example. And you can see here, so there's a circular part to it, but it sort of points up the back slightly, and so that would suggest that there was sort of shearing forces, and probably this person is sort of slumped or sliding down the bed or chair. Pressure is usually over a bony prominence, and you're more likely to have slough and necrosis in there, and the lesions are more likely to be deeper than the moisture. So hopefully those things will help you work out what you're looking at. Of course, both things can happen at the same time. Okay, so incident reporting. What you're asked to do by Oxford Health is to report all pressure damage from category 1 and up. That is the goal, that is the ideal. It's an absolute must for category 2 and above, and you report all of this on Ulysses. But really, we would like to be knowing about all pressure damage that's out there. So we would be asking if you would please report anything from category 1 upwards. Moisture lesions and medical device related damage also needs reporting, and those are separate things. So category 3 and category 4 pressure damage is going to be subject to an initial review by your CDL or senior nurse to establish if any level of harm happened, were there any emissions, and is there anything that needs investigating. If there is, that's when it would go to a SIRI for further investigation. Okay, so that is the end of the presentation. Does anybody have any questions for me? And I'm sure there must be some, so don't be shy.
Hi.
Hello, who's that?
My name's Amy. I'm with the district nursing team in Casterton.
Hi, Amy.
When I've done my pressure damage training before, they said that that pressure damage can happen everywhere, but you're saying usually on bony prominence. But I'm a bit confused because I've been told that anywhere there's skin can have pressure damage.
Okay, so if you think about how pressure damage happens,
yeah.
It requires this, in simple terms, it requires the squeezing of the tissues so that the blood flow doesn't flow, and then those tissues die. So it depends. If you tied a belt around the middle of my arm and kept it tight there, yes, I'd get pressure damage at that point, because you'd be so squeezing my arm that it would cut off the blood supply, and those tissues would die. Commonly, unless there's something like that going on, if it's down to you and your body, and you know, your internal wellness and what's happening sort of to your environment in terms of continence, nutrition and all of that, it's usually the contact between your body and the surfaces that it's lying on or sitting on, or your feet, you know, how you come into contact with the world around you. And it's usually over those bony areas, because anatomically that puts something hard on the other side of the tissue. So you have the bone that's hard on one bit, you have the surface that's hard on the other, and the tissue's getting squashed in between. So yes, in theory, you can, if you apply enough pressure onto an area, you can do that, but it's not the normal place to get pressure damage.
Okay, and
sense?
Also for deep tissue, what would you recommend for a deep tissue? How would you heal that?
Well, the most important thing is to take the pressure off. And if the skin is intact, we would say don't cover it, so that you can observe it, because if you can see something, you're far more likely to take care of it. So if you've got deep tissue injury on somebody's heel, for example, and carers or the patient indeed themselves can see it, they're far more likely to do the right thing and keep the pressure off that area. And then you would wait and watch and see what happens. Sometimes the body can recover some of that, or it can deal with it internally. And if you're really lucky, the body will just, a little bit like a serosanguinous blister, it will just reabsorb the damage inside, break the dead tissue down, reabsorb it without you actually getting a break in the skin. And it's a question of watching and waiting and time, really, because that deep tissue injury, probably within a week, it will have defined itself, if you like. So to start with, it will just look purple. If you've got the pressure off quickly enough, then it might just recover over the next few days with no further pressure. If you haven't, then you will watch it gradually over the days get blacker and drier and the skin break, and then it's eschar, and then it all starts to weep, and then it all starts to break down, at which point of course you would need to put dressings and things on it. So the most important thing is to take the pressure off.
So if you did all that but they don't follow it, it's going to get worse basically.
Probably, yes. If you're not if you haven't removed the cause because the patient won't do what you're asking them, yes.
Okay, thank you.
That's all right, you're welcome. Anybody else? Is it previous or current pressure damage or both that would score someone as high on Braden? Both. Yep. What is undermining and tunnelling? Oh, right, so undermining and tunnelling is, so imagine you've got a cavity wound and you've got an opening that's, say, 4 centimetres wide, but when you put your probe inside it, or when you look, you can see that the wound is wider than the opening. So that is undermining. So the skin is covering a cavern, if you like, underneath. And what you would need to do would be to measure that cavity. And so you would use a probe, and we use the clock technique. So on our website in the resources document section, there's a clock mapping sort of sheet where you go round the wound probing like you would do the time round a clock. So say 12 o'clock would be pointing towards the head. You would probe the wound pointing towards the head and see how much undermining you've got there, and then you'd record it on your clock at 12 o'clock saying it goes under 1 centimetre at that point. Then you move your probe around a little bit to 1 o'clock position and you'd probe there, and then you'd record how far undermining you've got all the way around the wound, and that helps you map out how big your wound is when you've got like a 3D effect going on. So for a superficial wound or the top surface area, you would map and you would do the surface area, but with a cavity that's got undermining, clearly the wound is a lot bigger than that. Let's going down. Somebody else. ProShield and Derma S. What is the difference and when to use them? Jolly good question, and something that people get wrong. So these are barrier products. We do have a barrier pathway. It's not here in front of me at the moment, but on the website there is the barrier pathway there that has all of the different barrier products and pictures and descriptors of all of the different times that you would use them. So I would suggest, Lily, that you would go onto the website and find that and print it off for yourself, maybe stick it on the wall or laminate it and take it round with you. Because if you're anything like me, I still have to go to that and go, now hang on a minute, which is the right product for this? Because Derma S, of course, comes in 3 different formats, really, doesn't it? So Derma S comes as a cream. It comes as the non-sting barrier film in an aerosol format, but also in the little sponges that you use to paint onto the skin. And they're all appropriate for different sort of scenarios. So the Derma S cream is a barrier product for intact skin and skin that's not suffering with moisture damage. I know it sounds a little bit strange because it's meant to be a barrier against moisture, but if you've already got moisture damage in the skin, you don't want to be using a barrier product that's moist. So if you think of cream, moisturiser, don't put a cream on a moist skin. That is when you would be using the spray. On a bottom where you've got moisture damage, you would use the Mediderma S spray, and then the foam buds are used for wiping around wounds. So leg ulcers, for example, you wouldn't want to spray the margins of a leg ulcer because you'll be getting the barrier spray in the wound bed, but you use the foam buds to paint around there. But you wouldn't want to use the foam buds to paint on a very sore moisture lesion on a bottom, so a spray would be much better for that. ProShield, people often use ProShield inappropriately, and you need really to think of ProShield as being more of a dressing than a barrier cream as such. It's very high tech, it's got silicone in it, it's not just a cream. And really, it's for putting over far more substantial wounds than a simple moisture lesion. Moisture lesion, Derma-S spray. Deeper wound, I mean, I've seen Sarah Gardner put ProShield on a necrotics or on somebody's sacrum where you couldn't get a dressing to fit. There was so much incontinence and it was all falling off and the dressings were holding things in place. And so we used the ProShield as like a dressing and gel format, if you like. So it's for far more significant breaks in the skin than just superficial moisture damage. I hope that helps. Go to the website, have a look on the barrier pathway. Anybody else? No? Okay, that's great. So I'm going to stop recording at the moment and make sure that you tune in next week, and then for the equipment one later over. Do you have to refer to TV for ProShield? You don't have to refer, but you don't have to fill in a referral form, shall we say, but yes, it's in the red section in the formulary, which means that you should be contacting us to talk through, is that the appropriate product for your patient? Because, you know, clearly, holistically, there may be all sorts of other things that you need to do. You know, do they need to be referred to bladder and bowel? Is there a better way of handling the exudate in a wound? Although you wouldn't use ProShield for that anyway. But yes, so email into us, give us a picture, give us as much information as you can, and then we can say whether we think that's appropriate or not. Cool, excellent. Thank you very much, Rachel. That's lovely. Thanks, Nicola. All right, bye guys. I'm off. I'm going to stop recording and say goodbye.